start the recording. And I do believe we're supposed to have a break at about 10:30. Is that correct? And then we resume at 11 to 11:30. All right, so let's go ahead and let's start. So this morning we're going to be talking about sickle cell disease. All right. The objectives for this lecture, we're going to look a little bit about the background, the pathophysiology of the disease, inheritance, how we make the diagnosis of sickle cell disease, and then we're going to go into what is important, the health maintenance and management of some of the common acute illnesses, and then we're just going to touch a little bit about disease modification and cure. So let's start off. Can anybody tell me what exactly is sickle cell disease? Can somebody raise their hands? Can anybody tell me what exactly is sickle cell disease? All right. So okay, so let's back up. Brian, all right, go ahead for me. Go ahead, Brian.
Yes, Doc, I didn't want to leave you hanging. So, sickle cell disease, it's a hemoglobinopathy, characterized by, what do I say, deformed red blood cells, um, leading to intravascular hemolysis. Yeah. Yeah.
Okay, so you said it's a hemoglobinopathy. You mentioned that it's characterized by deformed red blood cells, and you also mentioned that it intravascular hemolysis.
Yeah.
Okay. All right. Does anybody, a little incomplete, does anybody else have anything to add to that?
Hi, good morning, Doc.
Morning.
So it's a autosomal recessive inherited disease. So it's also a quantitative hemoglobinopathy, if I remember correctly.
Quantitative?
I think no, sorry, qualitative.
Okay. All right.
So it's characterized by the presence of HbS as opposed to normal adult hemoglobin HbA.
Right.
And I think that's due to a substitution of, I want to say, glutamate for valine on the beta chain, but I'm not sure. I can't definitively say, but I think so.
Okay. Anybody has anything else that they want to add? All right. So basically, the points that both Brian and was it Racine have mentioned are correct. Okay. So but kind of needs to be a little bit put together a little bit better. So we'll go ahead, we'll start. So sickle cell disease is basically a hereditary disease in which persons inherit the gene for an abnormal hemoglobin S, and this results in the production of your sickle red cell, so which is an abnormal shaped red cell, and is characterized by chronic hemolysis and vaso-occlusion. And I'm not sure why it is that the slides, when I put them into this Blackboard Collaborate, everything seems to be a little distorted. So I'm not sure what's happening here. So excuse, if you have some blockage of the text. All right. Now, sickle cell disease is not a very new disease. Okay, it's been around, known to occur in peoples of Africa for hundreds of years, and different tribes gave it different names based off of the cries of the persons who were undergoing what we now know to be sickle cell pain crises, right? And sickle cell has persisted in Africa, and that's where the highest burden of the disease is, okay? And that is largely because the sickle gene is protective against malaria. So we know that malaria is endemic in many areas in Africa. And if you put, if you look on the corresponding areas where malaria is endemic, are you seeing my oh no, that's not it. Are you seeing my pointer now? Okay. So if you look in the corresponding areas where malaria is endemic, you will see that these are the areas where there is a high incidence of the sickle gene. All right. And just to note that it is the sickle cell trait that is protective. So if it is that you have sickle cell disease, okay, malaria in a person with sickle cell disease is actually potentially fatal. All right. And these are just the, the names that the different tribes would give to sickle cell disease. So the Ga tribe called it Shiri Shiri Shiri, or however you pronounce that. The Yoruba tribe gave it the name Arun Aru Omo Legun Gun, which means illness that aches a child's bones. So although we know that sickle cell disease has been around for hundreds of years, it actually wasn't reported in the medical literature until 1910. And here is where the Caribbean plays a significant role in the history, because the very first person who was documented to have sickle cell disease was a person by the name of Walter Clement Noel, who was actually a Grenadian who was studying in Chicago. He was at dental school. And at school, he became sick, went to the Presbyterian hospital there. And you can see here, this is a copy of his blood, blood report. All right. And you can see that they have drawn what we now know to be sickle cells, with a description of very irregular, many elongated forms of red cells. All right. And so this paper, the peculiar elongated and sickle-shaped red blood corpuscles in a case of severe anemia, it relates to this first case of sickle cell disease. Walter Clement did graduate from dental school, went back to Grenada where he set up practice, but he unfortunately died around the age of 32 from what we now know to be acute chest syndrome. And he is buried in the Catholic cemetery in Salters. So, if anybody is a historian and wants to goes to Grenada, they can go to the cemetery, and there is a plaque here at the gate which commemorates that the first recorded case of sickle cell disorder lies in the cemetery. Following on from Walter Clement Noel, other cases were reported. It wasn't given the name sickle cell anemia until about 1922, and it wasn't until about 1949 that the inheritance and the issues related to hemoglobin S were understood. Now, because initially the first cases reported were all in Black people, okay, it was thought to be a disease of Black persons, all right? And still that's a kind of common myth that is held to this day. But we actually now know that sickle cell disease occurs in all races. It is truly a global disease, and a lot of this is related to migration, slave trade, and persons, moving to other areas of the world. It is a global disease, as I mentioned, and it's estimated that approximately 275,000 babies are born annually with the disease. Most of these will be born in Africa. Unfortunately, 50 to 80% of them will die before the age of 5 years, so it is a significant burden in some areas, all right? And because of this significant burden, the WHO and the UN General Assembly recognize sickle cell disease as a public health problem to bring greater awareness as well as resources to areas where disease burden is highest. If you look on the global incidence of sickle cell disease, and everything here is distorted because these red arrows are supposed to be with the Caribbean, okay, or the red circles, sorry. So Africa, we know, has the highest incidence, 10.1 babies per 1,000 live births. And what you will see is that the Caribbean has the second highest incidence of sickle cell disease worldwide. And so what that tells us is that if we practice in the Caribbean, any country, it is very likely, just as how you're going to encounter persons who have diabetes and hypertension and other chronic illnesses, you will encounter somebody who has sickle cell disease, and it's very important that you know how to manage persons who have disease. With regards to the incidence in Jamaica, 10% of persons in Jamaica have the sickle cell trait, all right? So 1 in 10. So if there are 42 of us here today, roughly 4 persons will have the sickle cell trait. Unfortunately, most persons who have the trait won't know that they have the trait because it is an asymptomatic disorder, it is a benign disorder, and unless you test for it, you are unlikely to know that you have it. Another 5% of persons have other significant traits, such as the C trait, the thalassemia trait, that puts them at risk of having a child with sickle cell disease. In Jamaica, again, 1 in every 150 babies born each year has a form of sickle cell disease. And so for our small island, we have approximately 200 to 250 babies born every year with sickle cell disease, right? Throughout the Caribbean, again, the incidence of sickle cell disease varies, all right? But if we look on the trait rate, all right, it ranges again from a low of about 3% in Aruba to a high of 10 to 11% in Jamaica and St. Lucia. Now, a lot of the data within the Caribbean is not very robust because there is not a lot of, screening programs or data on sickle cell disease, all right, throughout the Caribbean. But it really just shows us that sickle cell disease is in the Caribbean, and whichever part of the Caribbean that you may practice in, you likely will encounter a person who has disease at some point in your medical career. Okay, so let's go back to the pathophysiology. So Racine, I believe it was, had mentioned that you have an abnormal hemoglobin S, okay, and there is a substitution of glutamine for valine. And she believed it was on the beta globin chain. Does anybody else want to add anything else to that? Okay, so it's at position 6, okay, of your beta globin chain. All right, fair enough. All right, so let's just backtrack and talk a little bit about hemoglobin. So hemoglobin, we know, is that protein molecule in our red cells that carries oxygen. It's made up of 4 globin chains, and we produce different hemoglobins throughout our life cycle. And hemoglobin disorders can be either quantitative or qualitative. Sickle cell disease is a qualitative disorder of hemoglobin. If we look on the different hemoglobins that we produce, okay, in the embryonic stage of life, or in the embryo, okay, we produce embryonic hemoglobin, which doesn't last very long, maybe, a month or 2 sort of thing, all right? Our predominant hemoglobin in fetal life is our fetal hemoglobin, and that is made up of 2 alpha and 2 gamma globin chains. After birth, okay, your production of your hemoglobin, your gamma globin chains, starts to fall off, and you ramp up your production of your beta globin chains, all right? But in the initial few weeks after birth, you still have significant hemoglobin F levels around. After about 6 to 8 weeks, your gamma globin levels starting to fall, so you're still making hemoglobin F, but your hemoglobin F levels are falling. At the same time, your beta globin chains are production is rising, and as a result of that, your adult hemoglobin, for most persons that will be hemoglobin A, now takes over as your dominant hemoglobin in adult life. Just to note that there's an additional adult hemoglobin that may be produced, which is your alpha and your delta globin chains, and that is your hemoglobin A2. Hemoglobin A2 must not be confused with hemoglobin A. It is a minor hemoglobin, adult hemoglobin, which is present in the whole hemoglobin makeup of an individual. If you have a hemoglobinopathy, all right, whether it be a qualitative hemoglobinopathy, where you produce an abnormal hemoglobin, such as a sickle hemoglobin, or a quantitative hemoglobinopathy, which is related to your production of your hemoglobin A levels, all right, this is where the changes will occur and give rise to disease. Hemoglobin F, as I said, is the dominant hemoglobin in newborns, making up 60 to 80%. Levels after 6 to 8 weeks start to fall significantly, and by age of 1, we only have less than 2% of hemoglobin F in our hemoglobin makeup. But important to note that in sickle cell disease, the rate of fall of hemoglobin F after birth is much slower, and even after the age of 5 years old, persons with sickle cell disease can still have significant levels of hemoglobin F around, anywhere from 2 to 25%. But generally, for normal adults, okay, hemoglobin A, 95 to 98%. Remember, I said hemoglobin A2 that's a minor adult hemoglobin, 2 to 3%, and then you have a little bit of your hemoglobin F, anywhere from about 1 to 2%. And with regards to the variant hemoglobins, these usually occur from mutations in your genes that code for your alpha or your beta globin chains. Most are hereditary, and some will cause disease, and others will cause no detectable disease. All right? And these are just some of the common variants that we see. And as was mentioned, sickle cell disease, there is a substitution, okay? So the gene for your beta globin chains is on chromosome 11, all right? A point mutation in this gene results in a substitution of valine for glutamine. So valine replaces glutamine at position 6 in the beta globin chain. So you start to produce an abnormal hemoglobin, which is your hemoglobin S. And hemoglobin S, under certain circumstances within the red cell, has a tendency to form polymers, and these polymers lead to changes in the characteristics of the red blood cell. Now, can anybody tell me some of the differences in the characteristics of the normal red blood cell and the sickle red cell? What are some of the differences between the normal red cell and the sickle red cell? Anybody? Okay, so Rhea says a sickle cell is less hold on, I have to find it here. Okay, the sickle cell is less flexible and it is more sticky. Okay, and Abdullah kind of supports that. So it is a rigid cell. It is, and it's also low in oxygen states. It has a shorter lifespan. That's right, Gabrielle. And what is the difference in the lifespan between the two red cells? Anybody? What is the lifespan of a normal red cell? Okay, so Donna says the red blood cell lasts for 120 days while the sickle cell is less than 20 days. Okay, all right. So far we have the sickle red cell is a rigid, less flexible cell. We have that it has a shorter lifespan. And what is the other very obvious difference between the two? Okay, it has decreased oxygen carrying capacity. Okay, so the shape, exactly. All right, so with regards to the shape, all right, the sickle cell is sickle shaped. The normal red cell is a disc, biconcave cell. All right, so these are the differences or the simple differences between the two red cells, okay? And it is because of these differences, so these changes in the characteristics of the sickle cell, why we get the two kind of predominant pathophysiologic issues with regards to hemolytic anemia because of the increased red cell fragility, and also the vasoocclusions because of a rigid, sticky cell that tends to block the circulation and impair the blood flow through the vasculature. And a lot of the clinical consequences are related to these two, characteristics. Okay, so your hemolytic anemia gives rise to your chronic anemia, jaundice, gallbladder disease. Your vasoocclusion contributes to problems such as your pain, your acute chest syndrome, and your stroke. Okay, any questions on that so far? All right, so we mentioned that sickle cell disease, or somebody mentioned it's a hemoglobinopathy, it's hereditary, and somebody mentioned that it is an autosomal recessive inheritance. Okay, so what do we mean by autosomal recessive inheritance? What does that mean? Okay, so right, Gabrielle. So both parents have to carry the gene. So both parents, at a minimum, must be carriers or have a trait. Okay? Now, if it is that both parents have the sickle cell trait, what is the risk of having a child with sickle cell disease? 25%, correct. Okay, 1 in 4. And what does the risk change to if one parent has disease and the other has the trait? 50%, okay, all right. What is the risk of having a child with disease if one parent has disease and the other parent is AA? What is the risk of having a child with disease? Okay, very good. And what is the risk of having a child with disease if both parents have disease? 100. Okay, all right, excellent. And I always tell persons that don't think that this doesn't happen, because we actually have a family of 7, mommy, daddy, and 5 children who attend the sickle cell unit. Okay, so autosomal recessive, both parents must at a minimum be carriers of the abnormal gene, all right? And as a result of that, there is a 1 in 4 chance of having a child with disease with each pregnancy. And this is very important to appreciate, okay, because many times parents, you know, go back multiple times trying to, you have one child with disease, you go back again trying to get a child without disease, and you end up with multiple children who have disease. As I said, in Jamaica, 10% has the sickle cell trait, which means that 1 in every 150 babies born on the island will have a form of disease each year. Now, as I mentioned, if you are a gambling person, 1 in 4 odds are good, you know. 25% chance that you're going to have a child with disease with each pregnancy. But these odds really only pan out in large populations. When you think of about a small family unit, the odds often are not as great, all right? And here is an example of a family who Prof. Sargent met on his travels to India, okay? Mommy, daddy, both have the sickle cell trait, okay? And this is 8 of their 10 children, all right? One of child who had SS died. So of their 10 children, 8 had HBSS disease. One was AA, and I can't remember which one it is here, that was AA, and another had the sickle cell trait. But after that, all other 8 children had SS disease. So within a small family unit, okay, the odds are often less, you know, less, what's the word, good, or, you know, than the simple 1 in 25. Okay, now we speak about sickle cell disease, but sickle cell disease is truly an umbrella term, because whereas the most common form of sickle cell disease is HBSS, there are other forms of sickle cell disease. And what other forms of sickle cell disease are we aware of? What other forms? So there's SC, okay, that's another common one. Okay, so there's sickle beta thalassemia, all right, and can that be subdivided anymore? Okay, so there's sickle beta thalassemia minor and sickle beta thalassemia major. And can anybody tell me the difference between the two? Can anybody tell me the difference between the two? All right, we're going to talk about it in a little while. Not sure. Okay, fair enough. So apart from SC and your sickle thalassemias, does anybody know of any other forms of sickle cell disease that we see locally? Right, so there's SD Punjab, yes? Okay, so we also see SO Arab, S Lepore, SD Punjab, okay? So there are different types. Some are more common than others, and just as some are more common than others, some are more severe than others, okay? So SS is severe disease, S beta naught thalassemia is severe disease, SO Arab is severe disease, SD Punjab is severe disease. SC, sickle beta plus thalassemia, S Lepore, these are all milder forms of disease, but they are all still sickle cell disease. And just a reminder that you get other forms of disease because 5% of our population have other traits. So if you have a parent who has sickle trait and another parent who has a C trait, which again is a benign trait, then 1 in 4 chance of having a child with sickle cell disease, but the SC type of sickle cell disease. Likewise, if you have a parent who has a sickle trait Another parent who has the beta thalassemia trait, 25% chance of having a child with sickle cell disease, but in this scenario, it would be the sickle beta thalassemia. Now, thalassemia, as I said, is, okay, so this is just to tell you the different incidences. So SS is the most common one that we see, SC, your thalassemias, okay, and then after that we have the other rarer forms, SD Punjab, SO Arab, and so forth. So thalassemia is actually another hereditary disorder, but this time it is a quantitative disorder of hemoglobin. And so what is affected here is your production of your hemoglobin A. If you have thalassemia minor, you produce decreased quantities of hemoglobin A. If you have thalassemia major, you produce no hemoglobin A. All right? And so a person who has sickle beta thalassemia major, the only adult hemoglobin that they will produce is sickle hemoglobin. The person who has sickle beta thalassemia minor, the adult hemoglobins that they will produce will be sickle hemoglobin, but they will produce small amounts of hemoglobin A as well. And can anybody, just thinking on this, tell me what would be the difference between the sickle beta plus or sickle beta thalassemia minor and the sickle cell trait? Can anybody tell me what would be different? What was the difference between the two conditions? Okay. If you have the sickle cell trait, what hemoglobins do you produce? What adult hemoglobins do you make? A and S. Okay. Which one is in greater quantity? Which one is in greater quantity? A. Exactly. Exactly. If you have sickle beta thalassemia minor, that's right. So with sickle beta thalassemia minor, your levels of S are greater than your levels of A. With sickle cell trait, your levels of hemoglobin A are greater than your levels of hemoglobin S. Does everybody understand that? And that is how you would differentiate between the two. Well, one of the ways. Does everybody appreciate that? Okay. So sickle cell trait is a carrier status. Okay. Persons with sickle cell trait make hemoglobin A and hemoglobin S, but they make more hemoglobin A than hemoglobin S. On the other hand, persons who have sickle beta thalassemia minor, they too make sickle hemoglobin and hemoglobin A. But in this condition, they make more sickle hemoglobin than hemoglobin A. Is that clear, Ria? Okay. All right. And how do we diagnose sickle cell disease? Well, it's only a simple blood test. And persons with sickle cell disease can be diagnosed from shortly after birth. They can actually be diagnosed in utero if you do amniocentesis and that sort of thing. But certainly, typically, it would be diagnosis after birth, and that is a process by that we call newborn screening, whereby in Jamaica, all babies at all public hospitals, no, at all hospitals now actually, are screened after birth using cord blood, which is sent to the lab for testing, okay, to determine whether or not there is a possibility that this child has sickle cell disease. All right? And there are different methods of diagnosis. And the principle behind diagnosis is basically that we want to identify the hemoglobin makeup of an individual. We want to know what hemoglobins are present in your red cell. All right. Now we have screening tests and we have the definitive tests. Okay. So the screening tests are our sickle prep and our sickle solubility test. Does anybody know anything about either one of these tests? Anybody? Okay. All right. So the sickle prep and the sickle solubility test, as I said, are screening tests. With the sickle prep, blood is added on a film to a solution of sodium metabisulfite. This will cause red cells to sickle, okay? And when you look under the microscope, you will see sickle cells, all right? Then you have the sickle solubility test, whereby blood is placed in a test tube, okay, with another reducing substance. And what will happen again is that if you have sickle hemoglobin present, your red cells will break down, and what you will end up with is a turbid solution. So this is a sickle positive test, and this is a sickle negative test. Okay, so this sickle positive tells you that there is hemoglobin S present. And these screening tests are great for, because they're very simple, they're inexpensive, and they can be used to give you an indication of the levels of sickle hemoglobin within a population. But what are some of the drawbacks or the limitations of this test or these tests? Can anybody tell me? What are some of the limitations? Okay, so you cannot tell which type. Okay, so you can't tell which type. Okay, fair enough. But even before you go to which type, what else? Take a step back. Can you? No, false positives. Doesn't detect all, no. Oh, no, no, can't different. All right, so here we go. So Aliana, so it can't differentiate the disease from the trait, all right? Because disease and trait have sickle hemoglobin. So once you have sickle hemoglobin present, either one of these screening tests will be positive, sorry. But it cannot tell you if the person is disease or if the person is trait. So that is one limitation. What is the other significant limitation with regards to these screening tests? And it has to do with traits. Okay, how is it that a person who is sickle negative and a person who is sickle positive on a screening test can have a child with sickle cell disease? Why is that? No. There are other hemoglobinopathies besides sickle hemoglobin. Exactly. So if we go back up to this slide, okay, these two people can produce a child who has sickle cell disease. This parent will be sickle positive. This parent will be sickle negative. Likewise, if you have a parent who has the C trait and a parent who has the sickle trait, they can have a child who has sickle cell disease. The parent with the sickle trait will be positive. The parent with the C trait will be sickle negative. Everybody understands that, sees that? So if you have a person who only has a sickle test, all right, so the sickle screening test will only detect hemoglobin S, all right? So they are only positive if you have sickle hemoglobin present. A person with the C trait will be sickle negative, because they do not have sickle hemoglobin. The person with sickle trait will be sickle positive because they have sickle hemoglobin. But these two people can have a child with sickle cell disease. It is just that their child will not have hemoglobin SS, but will be another type of sickle cell disease, such as SC, or in the case of the parent who has thalassemia trait and the parent who has a sickle trait, it will be a child with sickle beta thalassemia. All right? So what I'm just saying to you is that using the screening test alone, you cannot reassure anybody who is sickle negative that they are not at risk of having a child with disease, because they could be in the 5% of persons that have other traits, such as the thalassemia, the C trait, that put them at risk of having a child with disease. Does everybody see that? And why I kind of try to ensure that you understand it is because many times in antenatal clinics throughout the island, parents, the mummies, are tested using the sickle test. And so you will have the scenario where a mother who is sickle negative is told after birth that her child is sickle positive, has sickle cell disease. And she will be, but doc, I don't understand. How can my child have sickle cell disease and I have no sickle? I am sickle negative. And it's simply that mommy has either the C or the thalassemia trait. Daddy is the one with the sickle trait, and they have a child with SC or sickle beta thalassemia most commonly. All right, everybody gets that? Okay. With regards to definitive tests, so the screening test, as I said, does have its benefits, but it does have its limitations. So ideally, what you want to do is you want to do a definitive test, a test of hemoglobin analysis, of which there are different types, okay? The common one, or the very old-time method, is the hemoglobin gel electrophoresis. And then we have the newer methods, HPLC and isoelectric focusing. Gel electrophoresis, very simple, inexpensive. It's labor intensive, however, and basically hemoglobin separate dependent on their charge, okay? So their charge affects their speed of migration, and what you would do is you would compare against the control. So this is a strip. This is your control, all right? And these are your samples, okay? So patient 1 has sickle hemoglobin and fetal hemoglobin on board. Patient 2 has only C, so this would be a patient who is CC. Patient 3 has a sickle trait, hemoglobin A and hemoglobin C. Patient 4, sickle cell trait, hemoglobin A and sickle hemoglobin. And normally when we do gel electrophoresis, we do it on 2 different mediums. So we would do an acid medium first, and then we would confirm our hemoglobins identified on an alkaline medium, which is your cellulose acetate membrane. And this is just what an actual strip from our lab looks like. So here in the middle, you have your controls, all right, and your hemoglobins migrate, okay, again, dependent on their charge. And these are different samples from different patients, okay. A lot of these are newborns, so you will have significant levels of fetal hemoglobin. This person has A and S, this A and S, this person has A and C, this is AA, this is A and S, this is A and S. All right, so basically you compare it to your control, you compare the position of the hemoglobin band to the control, and that will help you to determine what your patient has. HPLC is a newer method, it's a faster method, it's automated, and what you end up with is these graphs, okay, or these charts, again with different hemoglobins identified, all right? And that helps you to know what the hemoglobin makeup of an individual is. But then when you have all this information, what does it mean? Well, the first thing to understand is that hemoglobins, when they are recorded in order of quantity. So if you write SA, it's not the same thing as AS. This SA is sickle hemoglobin more than hemoglobin A. So this would be a person who has the sickle cell trait. Sorry, this would be a person who has the sickle beta thalassemia. This A and S is a person who has sickle cell trait. The other thing which we mentioned before is that in the first few weeks after birth, hemoglobin F is going to be in greatest quantity. So hemoglobin F will always appear first. So in the first 6 to 8 weeks, your results will always look like this: FA, FAS, FSA, F and S, because hemoglobin F is in the greatest quantity. As your hemoglobin F levels start to fall off, then your hemoglobin F will fall, will be placed after your adult hemoglobins. And when we're trying to determine when we're trying to interpret our hemoglobinopathy, we are going to focus on the adult hemoglobins present. And if S is the greatest quantity, then that person has sickle cell disease until proven otherwise. So all of these results here, FS, FSC, SF, SS, SA, SC, all of these results suggest that these persons have sickle cell disease. These are from babies. You ignore the F. S is the adult hemoglobin present. S and C, S is in greatest quantity. This is probably a child who is maybe 9 months old. Fetal hemoglobin is still present, but S is the only adult hemoglobin. This one is straightforward, SS. This again, S and A are present, but S is in greater quantity than A, so this is sickle cell disease. This is S and C, so this is a person with SC disease. Does everybody see that? Does everybody appreciate that? Because it's okay, fine. All right. So when you're looking on results, focus on your adult hemoglobin. And once your sickle hemoglobin is a predominant hemoglobin, then that person has sickle cell disease until proven otherwise. And just again to highlight some of the common patterns that we see, okay? So sickle cell anemia, which is SS, Remember, as I said, in the first 6 weeks of life, F and S. After that, you will see S plus or minus F, depending on how much of the F persists. And F can present, levels can be anywhere from 2 to 5%. Sickle beta thalassemia not, remember, very similar to SS disease, only sickle hemoglobin present. But what helps us to differentiate sickle beta not thalassemia from SS disease is in that with beta thalassemias, your A2 levels are elevated. So A2 levels are greater than 3.5%. Hemoglobin SC, S and C, sickle beta not thalassemia, S and A, but S is greater than A, and also again with thalassemia, you have elevated A2 levels. This condition, called sickle hemoglobin, hereditary persistence of fetal hemoglobin, looks very similar to SS disease, okay? But in this disorder, person has actually inherited one sickle gene from one parent, and they have inherited the gene for the hereditary persistence of fetal hemoglobin from the other parent. And how we differentiate this from SS disease is that your hemoglobin F levels tend to be very high, over 30%. All right? And we would confirm this by doing studies on the parents where one parent would have the sickle cell trait and the other parent we would note would be hereditary persistence of fetal hemoglobin. Sickle trait, F, A, and S. A, so your levels of A greater than S, and the person who does not have any sickle cell hemoglobin, the only hemoglobin that they have around is adult hemoglobin, your normal adult hemoglobin. All right, you can study this in your, in your spare time, and to get a little better appreciation of these patterns. But the key thing to say, as I remember, once S is the dominant adult hemoglobin, that person has sickle cell disease until proven otherwise. All right. Any questions before we move on? Any questions before we move on? All right. So we're going to talk about disease management. We're going to talk about, common complications and how we manage them. So when we talk about disease management, I consider three very important focus areas: disease education and public awareness, early diagnosis through newborn screening, and comprehensive care. And disease education and public awareness is very important, and we each have a role as a healthcare worker in spreading correct information, helping the public to be aware. Because by doing this, if persons know their risks, know their status, then they can make informed decisions with regards to family planning, okay? It is often better going in knowing that you may have a child with sickle cell disease than hearing after birth that your child has sickle cell disease, all right? So you want persons to know to get tested, at some point, so that when they are thinking of having children, they can know what their partner has, and they can then make a decision: are we going to have a child together, than finding out after the fact, all right? And there are not number of leaflets and what we call IEC tools, information, education, and communication tools, that we use in the clinic here for persons who have disease. There are a number of public awareness, days. So, like World Sickle Cell Days held on June 20th every year. And we always try to have a lot of public education sessions. Certainly in the week surrounding World Sickle Cell Disease to basically spread awareness of the disease. Newborn screening. Have you all been on the postnatal delivery labor ward? Have you all been on labor ward? Yes? Okay. So you've seen these cards? Yes? Yes? Okay, fine. All right. So these are the newborn screening cards, okay, where cord blood is taken, and just a plug here to try and ensure that we get a good sample. So this sample here, which is basically a smear, is no good. You want a sample where it occupies about 2/3 of the blanks of the space provided, and you want the blood to be soaked through from the front to the back of the card. Okay? And as I mentioned, newborn screening occurs in all public hospitals and private hospitals in Jamaica now. And so there's no reason why any baby born in the island should not be diagnosed with sickle cell disease from after birth. And why do we want to diagnose early? Because there is a window period, okay? Remember, in the first few weeks after birth, because of high levels of fetal hemoglobin, it means that there is an asymptomatic period. And so newborn screening allows for early diagnosis, and it allows us to enroll persons or babies into a program of comprehensive care, all right? And generally for any screening program, we must remember that screening is not just a testing. You screen because you want to do something about the problem. So we screen for cervical cancer. We screen for prostate cancer because we know that if we detect it early, then we can, decrease morbidity and mortality associated with the disease. All right. In early childhood for sickle cell disease, asymptomatic period, symptoms are unlikely to occur before age 4 months. And that's because you have fetal hemoglobin high levels, which are protective. Dactylitis, which we will talk about, is the most frequent initial complication. And this is often missed or misdiagnosed. And the first 3 years is a very vulnerable period with sickle cell disease because it is the highest period for death, okay? And the two conditions that contribute to the highest mortality are what we consider preventable deaths. So once we have diagnosed early, we want to enroll in a program of comprehensive care, and this focuses around health maintenance, prompt identification and treatment of acute complications. We want to prevent and limit morbidity and mortality from chronic complications, and we also want to modify disease if appropriate. And as I mentioned, the risk of death is highest in the first 3 years, okay? But because of comprehensive care, we now have increased survival. So the median survival now for a person who has SS disease is 42 years, okay, which is very good compared to 20, 30 years ago. But this is just kind of the median, persons will be older, live longer than that, all right? So this is our oldest patient. He's actually still alive today, so he's probably about 93, all right? Bedridden now, so not as good health, all right? But he is our oldest patient, okay? And this was him at the clinic when he came for his 90th birthday check, all right? But that's one of the reasons why, we want to have comprehensive care so that we can detect and complications, we can educate, and we can provide opportunities to treat and delay complications such as renal failure, which are emerging as persons live longer. Just to say that this patient doesn't have SS disease, however. Again, when we're talking about, health maintenance, we have to appreciate that sickle cell disease is a very variable disease. Okay, no two persons behave the same way. We talk about mild and severe forms. So SS, sickle beta naught, your severe forms, SC, sickle beta plus, mild forms. Other genotypes, SO Arab, SD Punjab, severe, S Lepore, mild. But even within your genotypes, you can have a lot of disease variability. So SS, typically a severe disease characterized by increased susceptibility to infection, the likelihood of ASS, vaso-occlusive crisis, your pain crisis, death in early childhood. It can be an incidental finding in a 60-year-old to 70-year-old, and we've had that. And again, just to stress or to highlight the disease variability, this is Prof. Sargent with 2 of his patients years ago. Violet, a known patient, 13, she had sickle beta naught thalassemia, and she had a relatively severe clinical course. This is her sister, Myrtlin, who was younger than her. Can anybody tell me some of the stark differences between these 2 ladies, these 2 girls? What are some of the differences between the 2? Anybody? Okay, so weight. You call the body habitus the same? All right. Okay, so Violet looks younger. The effect is different. Okay, let me see what else you're saying. Okay, so affect is one thing. So, Myrtlin looks quite like a happy child. Violet, on the other hand, looks very sad and kind of forlorn. Violet is 13, and you can see that she remains prepubertal. Okay, all right. This is her 11-year-old sister. And just in body habitus, Myrtlin looks a little bit more robust, Her muscle mass, she looks a little more weightier than her 13-year-old sister, Violet. But can I tell you that both of these children had sickle cell beta naught thalassemia? Okay? So these are 2 siblings, same mommy, same daddy. This child, Violet, who is 13, sickle beta naught thalassemia with a severe course. Her sister, Myrtlin, 11 years old, also sickle beta naught thalassemia, and a completely different course from her sister. And so this is just to highlight the importance of managing each patient with sickle cell disease as an individual, okay? Because the clinical course can be very different even with the same genotypes. Everybody gets that? Yes, everybody gets that? Okay. All right. Just a general framework for health maintenance, focus areas, routine health visits, okay, just for your checkups, immunizations, routine blood tests, pneumococcal prophylaxis, so we'll talk about that, splenic palpation, we want to screen for complications, and then there's disease counseling and education, as well as educational and dealing with educational and social issues associated with our patients. All right, so we're now going to complications, or to acute, mostly common complications and their management. Sickle cell disease is a disease of blood, so every organ system can be affected. Wherever blood flows can be a problem. Your complications can start as early as 4 to 6 months. As I mentioned, there's a lot of variability, and pain is a hallmark of disease. Many of the complications associated with sickle cell disease have pain. And these are some of the acute complications, okay? And these are some of the chronic complications that we see with disease. So we're going to talk about the complications, kind of going through the years in terms of, what's common from what's not common. And just to remind you here what's happening. Sickle red cells, they're sickling, vaso-occlusion, impairing blood flow to affected area of the body. So pain is the insignia or the hallmark of sickle cell disease. And this acute sickle cell pain can manifest from very early, and it can recur throughout the lifespan of the affected patient. What condition are we showing here? Anybody? Dactylitis. Okay. And what exactly is dactylitis? What is dactylitis? Inflammation of the joints, not quite right. Anybody? Vaso-occlusion in the digital bones. Okay, so more along that line. So basically, dactylitis is a vascular necrosis of the small bones of your hands and your feet. Okay? Now, I like this quote because it tends to put things into perspective with regards to pain. So for the person in pain, so incontestably and unnegotiably present is it that having pain comes to be thought as the most vibrant example of what it is to have certainty. For the other person, it is so elusive that hearing about pain may exist as a primary model of what it is to have doubt. So pain comes into our midst at once, that which we cannot confirm and that which we cannot deny. And it basically tells us that you can't look on somebody else and determine whether or not they're having pain or not. Pain is very subjective. And so if someone says that they are in pain, we need to believe them and manage them accordingly. In sickle cell disease, there are roughly 3 different types of pains. We have our acute painful crisis, and this is a #1 cause for hospital admissions. We have chronic pain, and this is often associated with pathology such as avascular necrosis of the femoral head, leg ulcers, and then you actually have patients who just have intractable chronic bone pain, all right? And then more and more we are recognizing the importance of neuropathic pain because of damage to the nerves, okay? And this pain is often doesn't respond to your traditional painkillers, and so you often need adjuvant therapy to help these type of pain. And again, painful crisis and many of our complications associated. And this study, the Pisces project, was actually a very pivotal study in the sickle cell disease because it basically looked on pain. And what it found out was that there's a pain prevalence of over 95%. Sickle cell can cause daily pain, and sickle cell pain can occur daily and is often more severe than previously thought. Okay? So most persons with sickle cell disease will experience bone pain, acute pain, at some point in their lifespan. And oftentimes what we see at hospitals, is the kind of the tip of the iceberg, because most persons with sickle cell disease try to manage pain at home and avoid hospital emergency room care. And so by the time a person presents to hospital, it means that their pain they are unable to manage their pain at home. And so we always have to bear that in mind. Acute bone pain is a unique pain. It's a combination of hypoxia, reperfusion. ischemia and inflammation. Acute pain crises increase in number, frequency, and intensity as patients get older. And patients with more frequent pain crises have higher mortality. This we see all the time. And it is increasingly difficult to treat with age and tends to lead to the development of chronic pain. Chronic pain also develops with increasing age, and it occurs in about 30% of adults. It's multifaceted in etiology, often associated with pathology, and it's associated with more functional and psychosocial morbidity, unemployment, absenteeism from school and work, and a multidisciplinary approach to treatment is required when we are dealing with chronic pain. It is one of the most significant challenges in management of persons with sickle cell disease. Dactylitis, as I mentioned, your avascular necrosis of the small bones in your hands and your feet, usually the first sign of sickle cell disease in infants from the age of 4 to 6 months, and treatment here is basically symptomatic. Your acute bone pain crisis, common risk factors, more common in males and females. It's more common in your teenagers, your young adults, your severe forms. Last trimester of pregnancy is associated with increased painful crises, and those persons who have higher hemoglobins and lower fetal hemoglobin concentrations. And we do know that higher fetal hemoglobin concentrations are associated with less severe disease because hemoglobin F is protective. So when we're dealing with somebody who has acute pain, and this refers to any form of pain, not necessarily sickle cell pain, we like to speak about A, B, C, D, E for pain management, okay? The first thing we want to do is ask about pain and assess the pain systematically. What are some of the things you want to find out when you are trying to assess a person who has pain? You want to find out about the character. Go ahead. The site and onset severity. Okay. Radiation. Okay. The pain scale, which is severity. Relieving and aggravating factors, exacerbating. Okay, fine. Okay, so you want to find out where the pain is. You want to find out the onset. You want to find out about the severity of the pain. And somebody mentioned about pain scale. So can you tell me a little bit more about the pain scale? How do we assess severity? What is the pain scale? Hello? Can anybody tell me about the pain scale? So there's a visual as well as a 1 to 10. All right. So basically, there is a visual, there's a faces scale, and then there is the numeric scale where you basically ask patients to rate their pain from 1 to 10, or from 0 to 10, with 0 being no pain and 10 being the worst pain of their life. Okay. All right. Okay, so this is a numeric scale, and this is the kind of the faces scale, the Baker 1 faces, which we can use in children, again, just as a guide to determine how severe the pain is. Now, in also assessment of our pain, all right, remember that pain may be associated with other complications, so try to determine if there are other issues going on, and we also want to assess the possible causes such as dehydration, infection, hypoxia, and any possible stressors that may have resulted in the pain. B is believe the patient, okay? If we don't believe our patients, then we can never treat them properly. C is choose appropriate pain controls. And is there a tool that we're going to use to guide us to determine in choosing our pain medication? Okay, the WHO pain ladder. Okay, so tell me more about the WHO pain ladder.
Morning, Doc. Honestly, Canberra typing that, so I'll try to.
I hear the typing, but you also like the typing, so go ahead. So go ahead, actually,
No,
go
I
ahead.
Canberra typing that response. So I know that it's I would say it's a system used to administer analgesics depending on the patient's level of pain. So you would start from I think paracetamol. And then, but the categories, so you have the paracetamol, you have non-opioid analgesics, opioid analgesics, so you're scaling up each time. And you also
Mhm,
have adjuncts. So,
mhm.
so like I said, you start from your paracetamol. If that's not working, you go, you try a non-opioid with adjuncts. I think that's not working, you go to your opioids and so on.
Okay, all right. Does anybody want to, and anybody wants to add anything to that? All right. So basically, your WHO pain ladder, your pain scale is a three-tier ladder. It speaks to mild, moderate, and severe pain. For mild pain, we recommend non-opioids, okay, such as your paracetamol and your NSAIDs, plus or minus adjuvants if needed. For moderate pain, we talk about using of a weak opioid along with your non-opioids and your adjuvants if necessary. And with step 3, which is severe pain, you substitute your weak opioid for a strong opioid at the same time maintaining your non-opioids and your adjuvants. The key thing to remember is you're going to start your pain medication at the appropriate level. So if somebody is in severe pain, there's no point in giving them paracetamol and ibuprofen. You have to start them at what is recommended for step 3, which is severe pain. Okay? All right? And at the same time, you want to remember your non-analgesic management, such as your warmth, hydration, distraction, and you want to treat any comorbidities that may be associated with the pain. All right? And just again, some of the common medications that we see. So non-opioids, paracetamol, and your non-SED. So that's talking about things like your ibuprofen, your diclofenac, your cataflam. Your opioids, so we talk about codeine, which may or may be not their preparations, which combine it with paracetamol. And the other one that we have locally is tramadol. As I said, everything here in these tables is distorted. I'm not sure why. And then for our strong opioids, our drug of choice is morphine, but there are other strong opioids that are also available. With regards to adjuvant therapy, antihistamines, okay, we know that a lot of our opioids, morphine for sure, can cause intense itching. And so itching with morphine is not an allergy, it's just a side effect, and you need to prescribe an antihistamine along with it. And this also helps to potentiate the analgesic effect. Many opioids give you nausea and vomiting, all right, so you want to prescribe an antiemetic. Persons who are on opioids for any significant period can also get constipation, and so they may need to be given laxatives. And then for persons who you believe have an element of neuropathic pain, then you would want to prescribe your antidepressants or your anticonvulsants, because as I mentioned, your neuropathic pain does not respond to your traditional painkillers. Once you've selected what pain control you want to deliver your pain, these medicines in a timely, logical, and coordinated fashion. So you want to get that first dose of analgesic in early. You don't want to have your patient sitting, waiting to get that first dose of painkillers in. It is not, that's just not right. And when we're given analgesics, we try to encourage by the mouth, by the ladder, and by the clock. Okay? If for some reason you can't give by the mouth, certainly IV, IM, by the ladder, which means that we're using our WHO ladder, and by the clock, it means that we're going to prescribe our medication based off of the half-life and the pharmacokinetics of the drug. So we know that a drug is supposed to be prescribed every 8 hours or every 6 hours or every 4 hours. We're going to prescribe it as such, and we're not going to prescribe it PRN. And that's because when you give medications by the clock, so each of these is a dosing interval, okay? What happens is that you are maintaining your drug levels within therapeutic concentrations. When you give medications PRN, so you're dosing only when the patient becomes symptomatic, okay? What has happened is your drug levels have fallen below therapeutic levels and you're forever trying to catch up, all right? And so it makes it very harder to try and control your pain. So when you are prescribing pain medications, when you're on the ward, writing up a Cardex for a patient, don't write PRN because the nurses will give it only when the patient cries out. You need to pick your time, 6:12, 6:12, 6:2:10, okay? You need, if the drug is supposed to be every 8 hours or every 6 hours, if you're trying to control pain, all right? Once your pain is controlled, all right, you're going to wean patients off their medications. So just as how you step up the ladder trying to control the pain, once the patient's pain is controlled, and usually we say if they've been pain-free for a day or two, then you're going to step down the analgesic ladder, all right? And at discharge or whenever you're sending patients home, we always try to ensure that we empower patients, educate them so that they understand how to deal with their pain at home, educate them about prevention triggers, ensure that they have appropriate TTH, and also ensure that they have an appropriate follow-up to monitor what is happening. Now, although we speak of acute bone pain because that is the most common pain, all right, remember pain can be associated with other complications, all right, abdominal pain, also common, and there are many of causes that could contribute to abdominal pain in sickle cell disease. So we have the kind of right upper quadrant syndrome, which represents any kind of hepatic or gallbladder disease. So hepatic sequestration, gallstones, cholelithasis, cholecystitis, could be problems with the spleen. It could just be an abdominal painful crisis, where they have like an ileus. Or remember, they could have other problems, pancreatitis, acute appendicitis. So they could also have other problems that contribute to abdominal pain. Okay, so persons with sickle cell disease are at increased risk of infection. What sorts of infections are they likely to have?
Infections from like encapsulated organisms.
Okay, so encapsulated organisms, okay. And what sorts of encapsulated organisms are you aware of?
Is salmonella one? I'm not sure.
Come again?
Is salmonella one?
Salmonella, yes.
I don't remember the rest.
Anybody else? Haemophilus influenza, yes. Any other complications? Any other bacteria? Strep pneumoniae, Klebsiella. Okay, all right. So common culprits, the pneumococcus, all right, Haemophilus influenza, salmonella, and even E. coli, which is associated, can be associated like with UTIs. What can we do to prevent infections? Okay, because that's part of our mandate in trying to, as part of health maintenance. For pneumococcus, we recommend penicillin and prophylaxis, and there's also immunizations. For Haemophilus influenza, there's a Haemophilus influenza vaccine. For salmonella, it is basically educating patients about food hygiene. So you're in pediatrics, so it's very important that you are aware of the immunization schedule. So there's a standard routine immunization schedule from Ministry of Health and Wellness, okay? This is all children, but there are additional immunizations which are available for persons who have sickle cell disease. So all patients who have sickle cell disease must get a Hib booster at the age of 15 months, 15 to 18 months. They must also get 3 doses of their Prevnar 13, which is a pneumococcal conjugate vaccine, before the age of 1. And then they get a booster dose in the age 12 to 15 months. And then they get their Pneumovax, which is a polysaccharide vaccine, at the age of 4 years. And then they get a lifetime booster after 5 years. So all of these vaccines are available through the Ministry of Health and Wellness for persons with sickle cell disease. And so it is very important that we are familiar with the schedule so that we can ensure that children with sickle cell disease get these additional vaccinations. Yes, they are free. They're all free now. Okay? Now, in addition to vaccinations, which is mandatory for all children with sickle cell disease, those additional vaccinations, penicillin prophylaxis is recommended for severe genotypes. So your SS, your sickle beta naught thalassemia, these children from age of 4 months to the age of 4 years will get penicillin prophylaxis, and we stop the penicillin prophylaxis at the age of 4 after they get their Pneumovax. Penicillin prophylaxis can be given either IM, which is your Panadol, your benzathine penicillin G, which is every 28 days, or they can get penicillin V or amoxil orally, but that has to be given every day, twice a day. If they're allergic to penicillin, then they would get erythromycin or clarithromycin, and again, this would have to be given orally every day. For persons who have had proven, so they have had documented pneumococcal sepsis, meningitis, or pneumonia, those persons, it is recommended that they go on penicillin prophylaxis for life. And for those persons who have had a splenectomy, it is also recommended that they go on penicillin prophylaxis for a minimum of 3 years after the splenectomy. So these are just a little additional, cases where penicillin prophylaxis may be prolonged. Go back through what, Ashley? Penicillin prophylaxis for severe genotypes. We start at age 4 and we stop it at age 4. We start it at age 4 months and we stop it at age 4 years. We stop it once they've had their Pneumovax. Penicillin can be given either IM, which is your Panadol, every 28 days, or it can be given orally as penicillin V or amoxil, but it has to be given every day, twice a day. If you're allergic to penicillin, you get erythromycin or clarithromycin, but that is also given orally, either once a day for clarithromycin or twice a day for erythromycin. Okay? All right. I'm supposed to be 10:30, so we're supposed to stop shortly for half hour. But let me just do quickly salmonella. All right. So salmonella is foodborne, okay? And so we need to educate patients about handling and preparing foods, especially meats like chickens and associated foods such as eggs. So no raw eggs in any form. So no soft boiled, no sunny side up eggs, no cake batter, no licking of the, the bowl or the spoon when mommy makes homemade cake. No homemade eggnog, all right? No protein punch or, some men make a punch of cracker egg in there and they add malt and they add oats and all of these sorts of things. Nothing like that if you have sickle cell disease because of the risk of salmonella. And also, boys oftentimes like to go outside and they play with these lizards and sling them shut and whatever. But anyway, these things, these reptiles, pets can also carry salmonella. So you have to ensure hand washing, certainly after playing outside. And, certainly if you're having any dealings with any kind of pets or reptiles. All right. Not if it's homemade eggnog. If it's eggnog that's in a box that's been pasteurized, sure. But homemade eggnog is going to have raw eggs in there. Okay? So nothing that has raw or undercooked eggs. Rub? Rub doesn't have egg in there, Abdullah. You mean the eggnog will have rum, but the rum is not going to necessarily kill the salmonella. All right. So we're supposed to break now. Is that correct? And resume at 11? Okay. So we're going to stop here and then we resume at 11. Sharp? Okay. See you all back at 11. All right, 10:59. We're almost ready to resume. Anybody missing? Anybody missing? Okay, great. All right, so salmonella. What sort of infection is this associated with in sickle cell disease? Anybody? Osteomyelitis. Okay, great. So we know that osteomyelitis is common in sickle cell disease associated with salmonella infection. Osteomyelitis can often look like avascular necrosis because they tend to present in a similar fashion. All right. And we know that x-rays are often not very helpful in the first few weeks with an osteomyelitis. So you always have to have a high index of suspicion. All right. Now, what is going to be very important in trying to differentiate between osteomyelitis and avascular necrosis is getting either a positive blood culture or a positive bone aspirate. So you would certainly need to have the help of your orthopods in trying to determine this diagnosis. Okay. What other area in sickle cell disease is associated with avascular necrosis of note? We speak of avascular necrosis, so dactylitis. What other area do we have avascular necrosis that is very common in sickle cell disease? Right, the femoral head, exactly. All right. So yes, so avascular necrosis of the femoral head is fairly common in sickle cell disease, and so it's very important that we ensure that we take hip pain very seriously. All right. And if we suspect the diagnosis, then we need to stop our patient from weight bearing. So they need to go on crutches. All right. A simple x-ray can help. All right. You'll be able to see instead of a nice round ball and socket joint, you'll see an irregular shaped head of the affected femur, all right, and that is consistent with avascular necrosis. Needs to be co-managed with the orthopedic team, and if there is, challenges in management, if permanent damage occurs, because of persons don't wear crutches and that sort of prop things to help the hip to heal properly, then they may need a hip replacement as they age. All right. So avascular necrosis, always have that in the back of your mind when you have persons with sickle cell disease who have hip pain, especially hip pain that is prolonged. Okay. Aplastic crisis. Can anybody tell me about aplastic crisis? Anybody? Aplastic crisis? What is aplastic crisis? Okay, so basically aplastic crisis is a red cell aplasia associated with worsening of anemia, absent or low retic count, and it is associated with a parvovirus B19 infection. All right, often occurs in young children. Treatment is basically supportive. You need to give them a blood transfusion to restore circulating volume until their bone marrow recovers. You need to find out from persons, do they have other family members or other, or other close friends who have sickle cell disease that they are in contact with, because it is infectious, and it is likely that if you have other household members with sickle cell disease, that they too will develop aplastic crisis at some point, okay, within upcoming weeks. There seems to be an association with nephrotic syndrome after a B19 induced aplastic crisis, maybe about 2 to 3 months. So it's always something that we have to bear in mind. Acute chest syndrome. Can anybody tell me what acute chest syndrome is? Anybody knows what acute chest syndrome? Okay, so an acute chest syndrome is basically an acute onset of respiratory signs and symptoms associated with a new infiltrate on chest X-ray. Can anybody tell me why it is that we call it a acute chest syndrome and not just simply a pneumonia? Okay, so it may be due to other causes other than infection. Okay, so the pathophysiology, because it's multiple etiologies, okay, is why it's not called just an infection. So contributing factors include infection, possibility of embolism, especially fat embolism after a bone painful crisis, sequestration, and infarction. And in managing a patient who has acute chest syndrome, basically you need to do your general as well as your specific management. So general management includes your oxygenation, your hydration, your physiotherapy, and specific management includes things like your antibiotics. They may need blood transfusion, management of other comorbidities such as asthma, which is often associated with an acute chest syndrome. And certainly if they do need ventilatory support, then you need to ICU care. With regards to antibiotics, we should always have broad spectrum, as well as we need to cover with a macrolide, because a lot of acute chest syndrome is associated with atypical organisms. Acute splenic sequestration. Can anybody tell me what is an acute splenic sequestration? Okay, so basically an acute splenic sequestration is an acute enlargement of the spleen associated with a 2-gram fall from their steady state. Okay, it is a common complication in children and a common cause of morbidity and mortality. There is a tendency for it to recur. So if you've had one episode, you're more likely to have a second. If you have a second, you're more likely to have a third. Hence the reason that after a second episode of an acute splenic sequestration, we need to try and refer those persons for elective splenectomy. And if you remember, we spoke about prophylaxis. So after splenectomy, they should go on penicillin prophylaxis for 3 years after surgery. Splenic infarction is basically just a painful spleen, swollen, all right, often seen more in your milder genotypes, okay, but the difference between it and acute splenic sequestration is that you will not see that fall in hemoglobin. One of the important things of health maintenance is trying to teach parents, caregivers, how to detect an enlarged spleen in children. And so they are shown from day one how to feel their children's bellies to on the left side to determine if the spleen is enlarged. And they are advised that if they ever detect a swollen spleen or an enlarged spleen, then it is important that they carry that child to the nearest hospital right away. Some children will have chronic splenomegaly, okay, and for those children, we give them what we call a spleen stick. So we give the parents a spleen stick, which is basically used as a tool to help to measure spleen size, okay? It basically has an up arrow, it's a tongue depressor with an up arrow, and we mark the lower limit of the spleen. We put the arrow in the prepubertal, in the nipple line for prepubertal children, and in the mid-clavicular line for post-pubertal children. And this vertical distance here is a measure of the spleen below the left costal margin. Priapism is a painful, prolonged, purposeless penile erection. Common in about 42% of males with sickle cell disease. Mean age of onset is about 15, and it can occur as early as age 2 to 5 years. We tend to classify them as either stuttering episodes if they are under 4, or major episodes if they are over 4 hours. Now, why do persons with sickle cell disease get priapism? Well, the simplest thing is just to say that there is blood flowing into the penis, into the cavernosa. It's getting congested, sickling, not able to flow back out. But the urologist will say there's a lot more going on. Okay, there's actually some molecular dysfunction going on related to increased oxidative stress, reduced testosterone levels. So all of these are contributing factors. The key thing, however, is that priapism is a medical emergency. There's a critical window for permanent erectile dysfunction, which is 4 hours. So persons need to be educated that they need to get to hospital at 4 hours. So they can try at-home measures, which includes a warm shower, passing their urine, so emptying the bladder, drinking fluids, doing some light activity, and taking painkillers. However, if this is not helping, then they need to ensure that they get to hospital at 4 hours. When they do present to hospital, it is an emergency and they need to be managed as such. If they're not responding to these simple home measures, then other things such as aspiration and irrigation and shunting by the surgeons will be necessary. For those persons who have recurrent stuttering episodes, yes, you have to speak with the surgeons. They insert like a needle and they do some sort of irrigation procedure. When you get to surgery, you can ask about that. For those persons who have had stuttering episodes, we tend to recommend alpha adrenergic agonists, so like Sudafed, in the initial stages. If that's not helping, then we tend to refer them to for management with the urologist. For those persons who have permanent erectile dysfunction, then the only recourse at that point is the implantation of a prosthesis. There are a number of neurological complications that are associated with sickle cell disease. We're in child health, and so we're going to focus on your ischemic stroke, all right, which is not uncommon. 11% of children by the age of 20 will have an ischemic stroke. The highest risk period is the first decade, so that's the first 10 years of life, with a peak occurring between the age of 2 to 5 years. Important to realize that there's a 66% recurrence after the initial CVA. So 2/3 of persons who have a first CVA will go on to have a second CVA, with the peak period for recurrence being in the first 2 to 3 years after the initial event. What do we do? Well, for an acute CVA, basically, the gold standard of management is performing an exchange transfusion. One of the first key investigations that needs to be done is some form of brain imaging, because you want to ensure that it is not a hemorrhagic stroke, because those are managed differently. Bearing in mind that with a CT, you're in the first 48 to 72 hours of an ischemic stroke, it may be normal. However, if it was an hemorrhagic stroke, you would see the hemorrhage, okay? And for those patients, you want to do an acute, an exchange transfusion. After that initial, event, to try and prevent recurrent stroke, the gold standard is a chronic exchange transfusion program, whereby basically persons would get transfused every, say, 8 to 12 weeks trying to maintain hemoglobin levels less than 30%, and this has shown to be decrease the risk of recurrence to approximately 13%. However, any chronic exchange transfusion programs has its, downfalls, okay? Well, first of all, in Jamaica, we don't have the blood to support a chronic exchange transfusion program. And then you have the risks of like infection, iron overload, all of these for persons who are on chronic exchange or chronic transfusion programs. So what we do locally is we offer our patients hydroxyurea, and this has been shown to be effective in decreasing the risk also for second stroke. What about primary prevention? Can we determine which child is going to have a stroke or is at risk for stroke? And if so, what can we do? Well, there is transcranial Doppler ultrasound, which is a very simple, it's a non-invasive test, and we use it to predict the risk of stroke in children who are 2 years and above, from age 2 to 16 really, with sickle cell disease. And it looks on the blood flow through the transtemporal window in your anterior cerebral, middle cerebral, and posterior cerebral arteries. Your transcranial Doppler readings are categorized into as normal, conditional, or abnormal, depending on the blood flow, the velocities. Okay, abnormal are velocities which are over 200 centimeters per second, and these velocities are associated with an increased risk for stroke. As such, persons who have increased velocities, they are recommended to go also on hydroxyurea to try and prevent that first stroke. Okay, so we use hydroxyurea to prevent first stroke in children who have abnormal TCD readings, and we also use hydroxyurea to prevent second stroke in persons who have had a first stroke. Leg ulcers. Imagine having that sore on your leg for years. So you could appreciate that it is a distressing condition. Occurs in about 30% of persons who have sickle cell disease. Majority of them will have SS, and the peak age is anywhere from the age of 10 to 20 years. The pathophysiology of leg ulcers is very complex, so there are a number of contributing factors. So there is your venous, vaso-occlusion, there's venous incompetence, infection, chronic anemia, and also, at a kind of cellular level, there's the whole issue of decreased nitric oxide and bioavailability and impaired endothelial function. In terms of trying to prevent leg ulcers, we basically educate patients about skin care, all right, avoiding scratches, bites, trauma as best as possible, wearing proper fitting shoes, and certainly, ensuring that their skin is nice and supple, so nice and moisturized. If they do have ulcers, okay, then we encourage daily dressings, all right, as well as bandaging, and this bandage must enclose the heel, all right, elevation of the limb to try and improve healing. But we do know that once ulcers become chronic, so certainly once they're there for 3 months and beyond, they get very difficult to treat. Sickle retinopathy, proliferative sickle retinopathy, occurs in over 50% of persons with sickle cell disease, and sickle retinopathy of interest is more common in persons who have SC. So those persons who have SC sickle cell disease, although a milder form of disease in theory, are at risk for sickle retinopathy. As a result of this, all persons with sickle cell disease are encouraged to be referred for ophthalmology screening from the age of 11 years. So all genotypes should be referred for eye assessment from age of 11, and this should occur every year because you want to detect any changes very early on, which so that they can do, laser or something about it. You don't want to detect sickle retinopathy when the person presents with an acute onset of blindness, there is hemorrhage and retinal detachment, it is way too late at that stage. The kidney in sickle cell disease, a very unique system, organ, okay? And a lot of just the normal environment of the kidney promotes sickling and promotes, renal disease as persons with sickle cell disease age. And so there are a number of issues related to the kidneys that start from very early, hypersynuria, which is the inability to concentrate urine, okay? As a child, not a problem, you're expected to bedwet, you are, so it's not as children age and get older. Why am I having, okay, as children age and they get older, bedwetting becomes a problem, okay, and certain even with some of our adults. So we have to educate our older patients or adults about things that they can do to try and help with bedwetting, decrease in fluid intake, ensuring that they toilet before bed, ensuring that they wake in the middle of the night, and these sorts of things. Concern with kidney disease as our patients age, we need to screen them for microalbuminuria, which is an early marker of glomerular dysfunction, okay? And at which point we would like to start interventions such as ACE inhibitors or HU therapy to try and prevent frank proteinuria and further progression to chronic kidney disease and end-stage renal failure, okay? Because at this point, then you're only talking about renal replacement therapy, such as dialysis. In Jamaica, about 6% of our patients will have chronic renal failure by mid-30s. As I said, we want to screen early because of to look for microalbuminuria, which we know is a marker, and we have shown, studies have shown that it occurs in about 18.6% of our children. Some of the other clinical indicators that highlight, evolving renal disease, we watch their hemoglobins. Their hemoglobins are starting to fall over a period of time. Higher blood pressures, microalbuminuria, persistent proteinuria or hematuria, and a rise in serum creatinine, bearing in mind that because of hyperfiltration, persons with sickle cell disease will have lower serum creatinines than other persons. And as such, when they are approaching normal levels, that could be a sign of worsening renal function, okay? And if they have renal disease, they need to be co-managed with a nephrologist, okay? And as I mentioned, other therapies that may be included in their care. The other kind of complication that we see as patients get older is cardiopulmonary disease, okay? And this, along with renal disease, are the main causes of death in adults now with sickle cell disease, okay? And so we need to start monitoring our patients, our older patients, for signs of cardiopulmonary disease. It includes, shortness of breath with routine activity, increase in fatigue, lethargy, syncope, peripheral edema, decreased appetite. And these patients would need to be referred for echocardiography so that they can make an assessment of, cardiac function. Sadly, at this time, there's no proven effective therapy for pulmonary hypertension or sickle cell disease cardiomyopathy. But, we still do try with measures. These are chronic heart failure symptoms. Is that what you're asking, Abdullah? Right. So yes, so some of the symptoms are, are very similar. Yes. Okay. So the whole point is when you're seeing, if you have a patient who has symptoms such as this, you would start them, you would send them for screening and for further investigation. Now, the last thing with regards to health, to comprehensive care for sickle cell disease is the whole issue of disease modification and cure. Can we modify disease? Can we cure disease? And the simple answer to both at this point is yes. And how do we do that? Well, we know we can modify disease by hemoglobin F induction, okay, because we do know that hemoglobin F is a disease modifier. So persons who have sickle cell disease and have high hemoglobin F levels tend to have less severe disease. With regards to cure, we're looking on bone marrow transplantation and gene therapy. Hemoglobin F, one of the ways that we do that we modify disease is with hydroxyurea, okay. There's been a lot of work done with hydroxyurea over the years, so from about 1984 to 2017 and beyond, so over 30 years of experience now with sickle cell disease and hydroxyurea. And we do know that it works and it can significantly impact morbidity and mortality, okay? How does it work? Well, it has direct vascular effects, and it also has effects by increasing hemoglobin F. And all of these basically help to improve tissue oxygenation and decrease inflammation. And here is just a blood, film just to look at. This is somebody's blood film prior to hydroxyurea, and you can see there's a lot of sickle cells, very few red cells. After hydroxyurea at optimal dose, with what we call maximum tolerated dose, you can see that their hemoglobin is higher, there's a lot more red cells around, and there are a lot fewer sickle cells. So basically, their blood is a lot healthier, and it does help to improve their clinical course. Hydroxyurea, we've been doing a lot, as I said, has been around for a long time. In the past 3 or so years, 3 to 4 years, other treatments have come on board. So there's L-glutamine, which is an amino acid, and then this one, which I can never pronounce, crizanlizumab, and voxelotor. So these are newer treatments that have been available since 2019. None of these are available in Jamaica at this time, and they are also extremely costly. So not too sure at this point where, if and when they will reach Jamaica. With regards to cure, there's bone marrow transplantation. The first person transplanted was about in 1984. It was a child who was transplanted before, I think she had an acute leukemia, and her brother was her donor. He had the sickle cell trait. And after transplant, they realized that she had, in a sense, converted to the sickle cell trait. And that started all the work and all the research into bone marrow transplantation, which is now fairly standard treatment for persons with sickle cell disease who have severe disease. Thing about transplantation is that, it's mostly performed in children. You need to have a HLA identical matched sibling, and the transplant itself can kill you. So it's not a simple procedure. There are significant complications associated with it. A lot of the limitations at the moment with transplantation include the donor availability, all right, because you ideally want to have a matched sibling. Economic factors, transplantation will cost you anywhere from 150 to 400,000 US dollars at this point. And then you have the whole, the social cultural factors in terms of just, the whole issues related to transplantation and blood. And so it's there, but we have to realize that where the burden is highest, transplantation is not going to be an easy road or, a first line treatment at this point. And then we have a lot of studies being done now, a lot of work being done now in gene therapy. Okay, and again, looks very promising. There are a number of clinical trials which are being done. Basically, they take out your blood, harvest your stem cells. They correct the gene in your stem cells by adding either a gene for a modified hemoglobin F or a modified hemoglobin A, and then they transplant you back with your corrected stem cells in the hope that these stem cells will now stimulate and increase red cells productions, which have either higher levels of F or levels of A, and this helps to modify disease. The very first report of gene therapy was done in 2017, and this was a child who had SS disease, and he was, I believe, transplanted with a modified hemoglobin A. So he was cured. He was converted to a sickle trait, if you want to call it. That's the simplest way to say it. All right. But as I said, again, this is not standard therapy. It's still fairly experimental. A lot of research at the moment looks promising, but again, it's going to be very expensive therapy. Just to put a plug here for the clinical care guidelines, it's a very good resource tool, and we certainly encourage students, all healthcare workers, to get a copy to help you in managing persons who have sickle cell disease. This is us at the unit, and we don't only do clinical care, we do a lot of research and education in relation to sickle cell disease. And so in summary, it's a chronic hereditary disease, can cause significant morbidity, mortality. Advances in care have improved the outcomes, okay, but access to care is not universal at this stage, and there are curative treatments, but as I said, these are certainly not, standard of care or basic care, and very expensive and unlikely to reach areas where burden is very highest at this time. Okay, so I know that that's a lot of information. Are there any questions that anybody wants to ask at this time? Any questions? Okay, well, I will provide my email is Leslie, lesley.king@uwimona.edu.jm. So please feel free to make contact with me if there are any issues or anything that you didn't understand or anything you want to discuss a little further. Okay, please feel free to email me, and we can always continue our conversation. I will try and upload this version of the PowerPoint. My email is leslie.king. It's Leslie, L-E-S-L-E-Y. Okay, it says leslie.king@uwimona.edu.jm. Perfect. Thank you, Ria. That's it. All right. Have a great day, everybody. I'll try and figure out how to upload this. Thank you, Sabrina. Have a great day.